anybody ever listening in is please jump in with questions. Okay. If your microphone is muted, is type them in the chat box or the question answer box, and I'll be able to read them, or they'll be able to read them to me. And this is about you learning this stuff. This is not about me showing you my cases. Like, is this a great case or what? Am I great or what? This is not that. This is about, are you great or what? And so that's what I want to focus on, is so to teach you and train you and answer all your questions is, and I want to go through it in its entirety. I want to tell you up front, this is not like, well, this is part 1, and for part 2, you got to sign up for a course or take something, or, you know, put your credit card in for part 2 or anything like that. This is the entire thing, A to Z, nuts to bolts is, and so there's no, you know, leaving out any secrets or anything. Is I have no commercial sponsors. So number 1, you're going to get all of it. Number 2, there's no commercial sponsors. And so I don't talk about any products or pitch anything is at all. On my textbooks, I do get 10% royalties. So anytime someone buys a textbook of mine, if it's $150, I get $15. So I get is lunch out of it. Okay. But other than that, I don't have any sponsorships. And so we can jump into it. And again, if there's questions, is let's talk about them. Let's answer. So you get what you are here for. Is I title Autologous blood concentrates. And in the past, I've titled it PRP, or platelet-rich plasma, the original name for it. But these days, as some of you may have seen, there's so many different names: PRP, PRF, CGF, BioPRF, ... And it just gets so confusing that I've started now using a more generic term. Autologous blood concentrates is most often. And we'll talk about the biology, the research, the little bit on the phlebotomy, but a lot on the clinical applications, the things that would interest you is the most. And what this is growth factors, things that tell your bone to heal faster and better, things that tell your gums or other tissues to heal better or faster. And if you've got some physicians here, then it is for all of the different tissues. And those molecules that tell things to heal faster are a specific part of that blood. It's contained within the platelets. And the way we came up with this discovery, we didn't set out to discover PRP or discover platelet plasma or PRF or anything. We were just doing our clinical work. You know, we did a lot of surgery. This is the early 90s. And a lot of the surgeries that Marks and I were the guys that developed this and discovered this. The surgeries we do is bone grafting and relatively large bone grafts. And so Ruth is one of those, 74 years old, and she was totally edentulous with a severely resorbed ridge. And I'll show you in a minute what I mean by severely resorbed ridge is in her case. And now we've done 300 of these patients. And she was referred to us for reconstruction and dental implants. And is for these large bone grafts, we developed and published this new procedure that we call the Tentpole Procedure. And I'll show you that in just a minute. And for her, we used autogenous bone at that time, is because you'll see the size of it. Although these days, the same case we now do with bone in a bottle. We take the freeze-dried bone from the tissue bank, add in the PRP from the blood, and get these same results. And we did simultaneous placement of dental implants, even in the severely resorbed ridge. And so this is the severely resorbed ridge here. You know, if you look at that mandible, it's literally 3 millimeters. And those of you who do implants know that no one makes a 3 millimeter implant. And those of you that may not do implants, is I can tell you, is no one makes, say, a 3 millimeter is implant. And so so we need to graft this. And to graft, and here we can dispel a lot of myths that you may have heard that you can't grow vertical bone. And indeed, in Ruth's case and the 300 cases after this, we've grown vertical bone. And we, in fact, routinely grow vertical bone. And you can routinely grow vertical bone as well. And so that's just kind of a myth out there that you can't grow vertical bone. And now, where the teeth need to be, if you look at this model here, the teeth need to be here for the proper vertical dimension. So even if there was 3 millimeter implants on here, the teeth would need to still be here. So you would have this much acrylic on those 3 millimeter implants. I mean, it would be like a 45-pound acrylic denture sitting on those 3 millimeter implants. And huge is the crown to root ratio discrepancies is there. So the thing is when you have, if you imagine an orthopedic surgeon, they operate on a knee joint and they don't even bother to suture it up, it's going to get infected. You imagine ENT surgeon, he operates head, neck, leaves the wound open, doesn't suture things up, it's going to get infected. Imagine even worse is that orthopedic surgeon leaves the wound open and the patient would spit in there once a day. It's definitely getting infected. No one can get away with leaving open wounds, exposed bone and the patient spitting in it once a day, except us. I mean, if you think about it, every time you pull a tooth, you're leaving exposed bone and the patient's spitting in it, not just once a day, but all day long. And we are able to get away with that, and there's no surgical specialty that otherwise could. But what happens is the larger the graft, the more it mimics that orthopedic model. A tooth extraction, it's open, it's fine. Periodontal surgery, the periodontist opens a flap, they cure up the interproximal tissue, they close the flap, they don't have primary closure interproximally, exposed bone, it heals up just fine. But you take a chin block, a ramus block, and screw it in, if that flap opens up, you lose it, virtually 100% of the time. So in this case, if we were to grow bone vertically here and make an intraoral incision, if it opens up, if there's micro leakage is from the suture line, it won't take. And so we did is we decided, let's make the incision under the chin. So we made an incision under the chin here, extraoral, and then is no intraoral incision and place the implants. They're only in 3 millimeters of bone here, but it's all dense cortical bone because you got the dense cortical bone of the anterior of the mandible, the posterior, the inferior border, and the alveolar crest there. And so that dense cortical bone in that 3 millimeters, we had good stability. We took our bone graft and added it, and literally the only matrix band, so to speak, is the soft tissue. We just stuffed it in there like you would a sausage is into that. And at that time, we were looking for a way to glue it together. So we did is we're in the operating room doing these cases. We drew blood from the patient. In Europe, they're selling fibrin adhesive from blood banks. In the US, the FDA didn't approve that. And so we couldn't get this pre-made fibrin adhesive. So we're going to make our own crude fibrin adhesive. Drew blood, spun it in a centrifuge. The red blood cells went to the bottom. What's called serum or plasma goes to the top, and the middle layer is the fibrin. So we collected the middle layer and added it to this bone graft to make it sticky. And you can see that here. We got that middle layer and made it sticky, and now it held together better for handling. And then you can see the result for Ruth 3 to 4 months later. We opened her intraorally, and we've got bone growing all the way to the top of the implant. And in fact, we have excess bone. It's growing above and beyond the top of the implant because we'd stuffed extra bone in there. And so this is Ruth preoperatively. A week after the surgery, you can kind of see the wispy bone that's there. This is her from a side view. This is her 1 year later. Is biologically reconstructed mandible. And as I said, we now have done 300 of these cases. And that mandible has grown from angle to angle 15 millimeters tall. And with 6 15-millimeter implants, you can put in whatever kind of prosthesis you want. In this case, she got an overdenture, but that could have been a hybrid, that could have been all-in-4 type of prosthesis. It almost could have been, crown and bridge is there. And so what we were doing is getting that fibrin content, that middle layer. The top was the plasma serum, the bottom was red blood cells, and we were looking for the fibrin. What we noticed is the cases when we added this middle layer, the bone seemed to mature twice as fast. The bone seemed to be twice as dense. And we said, well, I mean, gluing it together is better for handling, but it shouldn't account for faster healing, and it shouldn't account for denser bone. What's going on? And that's when we began to investigate this. And we realized that that middle layer is not just concentrated fibrin, it's also concentrated white blood cells that fight the infection, so less chance of infections. But the most important thing we're talking about now, they concentrate the platelets. They're about the same specific density as the fibrinogen, as the white blood cells. So we would take the total platelets in a 10 ml test tube, grab the middle 2 mLs, so it would be a 5-to-1 concentration, right? 500% concentration of those platelets. And the platelets, you and I have been classically trained, they're there to stop the bleeding. And they're the first cell to arrive at the site of injury, whether you have a tooth extraction or a sinus lift or a knee injury or a paper cut. the first cell to arrive at the site of injury is the platelet. And again, we've all been classically trained that is to stop the bleeding. But it turns out it has a second equal or perhaps more important function. The platelet also has growth factors within it. So when it clots, it degranulates. It adds side chains to those growth factors and makes them fully functional and releases those. And that's what tells the bone or the soft tissue is to heal better and faster. And by increasing the platelet concentration 500%, we are therefore increasing the growth factor concentration 500%. So that's why I say we kind of stumbled on this discovery of platelet. And we call this mix then platelet-rich plasma because, of course, it was a plasma, the serum from the top, and it was rich in platelets. We actually could call it fibrin-rich plasma or a leukocyte, which is a fancy word for white blood cells, rich plasma. Or we could have called it platelet and fibrin and leukocyte-rich plasma. Right? Any one of those would be correct. Right? And that's why you have so much nomenclature these days, is irrespective of who's talking about it and what centrifuge brand that they use, they're always taking the middle layer. But some people will say, well, I'm going to give the star billing to the platelet. And some will say, I'll give the star billing to the fibrin. And some will say, I'll give the star billing to leukocytes. And that's why you see those letters, P or F or L, coming up so frequently, irrespective of what name anyone gives it. So as far as with the nomenclature, the name, it's all the same product. It is always the middle layer. Sometimes folks do it for ego. They go, well, I developed this particular initials. And so they do it for the ego. Or sometimes is marketeers will do it and say, well, our centrifuge makes XYZ PRP or ABC PRP. And they'll give it a specific name for marketing purposes. And so the end user then gets confused. Well, is ABC PRP better than XYZ PRP? Or is PRF better, or LPRF, or APRF? Or it's always the middle layer. It just what that marketer is calling it, or for his centrifuge, or what that clinician is calling it for his ego. And so you as clinicians don't need to get bogged down in that. It's the middle layer. And so you can call it whatever. Rose by any other name is still a rose. And so we're going to take that middle layer, which is the concentrated platelets, to give us the concentrated growth factors. It does make things a lot stickier and hold together better because of concentrated fibrin. It does mean less is infections because of concentrated white blood cells. Those are just extra side benefits. And because of concentrated platelets, after surgery, you can have some oozing and bleeding. But if you got concentrated platelets, then you get less oozing and bleeding. And so less oozing and bleeding, less swelling. And so when you're using this PRP, a side benefit is not just faster healing and better is soft tissue and hard tissue, but less oozing. And then is less swelling. And what happens with swelling, when things swell, they put pressure on the nerves. And so with less pressure on nerves, you get less pain. And so is with less swelling, less sutures popping open. So better healing. So you get all these other benefits in addition to the main benefit, which is faster healing and better healing, is you get less sutures popping open, less swelling, is less pain, is all from this. And literally the centrifuge is, you can get a kit that is the centrifuge, about 100 test tubes, about 100 tourniquets, 100 needles, is sort of the whole shoot match, everything you need for the first year or two in your office, and for about $1,600. And after that, subsequently, each of the test tubes is 50 cents. And so once you've paid for that centrifuge, it is a per patient cost of about 50 cents for the test tube, about $1.50 for the needle and the tourniquet. So $2 per patient is overhead cost on it. I mean, negligible. And in that 1,600, you actually have enough for the first 100 patients of this. So the cost is almost nothing. I mean, it's $2 per patient. So that platelet, it goes around in the bloodstream. They shouldn't clot. Is if they clotted and that clot goes to the brain, that's called a stroke. If the clotting goes to the heart, that's called myocardial infarction. If the clotted spontaneously went to the arms or legs, that's phlebitis, and they, is clog up that part of the artery, and then as you lose the blood flow there. So you don't want spontaneous clotting. But what Mother Nature's cleverly done is had clotting when it's exposed to air. So if there's a paper cut or a tooth extraction or any other injury, it's exposed to air, now it changes shapes. Now it releases growth factors. It clumps together to make a plug and stop the bleeding. And evolutionarily, is whether you believe in divine intervention or evolution or what have you, it makes a lot of sense, because you got those animals in the plains of Africa running around, the ones that get bitten and don't clot from air, they die off and don't have progeny. The ones who get bitten and do clot from air, is they go on, stop bleeding, and go on and have progeny after that. So it's a good survival mechanism. Interestingly, is it clots from glass. Now you go, okay, air, I understand. Why would Mother Nature or divine intervention cause things to clot from glass? And I don't know. There's nothing in the literature about it. My own theory is this: that is not the glass per se, it is the silica content of glass. That same animal in the plains of Africa that couldn't stop bleeding from air because too big of a bleed, rolls around in the sand, is able to stop bleeding because the silica in that sand is able to go on and have progeny. So I think there was an evolutionary benefit to being able to stop the bleeding from silica. Nonetheless, however or whatever the reason is, we know that with glass, that it will stop the bleeding. All right? It will cause clotting. And the reason that's important to talk about, that if I wanted a clotted version of PRP, I would use a glass test tube. If I want a liquid version of PRP, I would use a plastic test tube. If I want a better clot formation, I would use a glass Dappen dish. If I want a liquid version, I would use a stainless steel Dappen dish. All right, so that's where it may come into play, is clinically when we want clotting, glass things. When we don't want clotting, non-glass, plastic is items.
Hey, Arun, can I interrupt you here a minute?
Of course, absolutely.
Someone asked about, it was kind of interesting when you talked about the acronyms and the change in letters and big marketing or ego, which I agree. Someone asked about APRF, A-PRF, and they said, is that marketing too? Is that the same deal you're talking about?
Yes.
Okay, good. Also make sure.
And I can go as much, a bit more detail, is when we first published it, it was PRP for probably about 10 years, 12 years. And then a Moroccan fellow, is a non-dentist, non-physician, a perfusionist, worked in the OR. And so he gave it a name, PRF. And so he gave it a name because what he did a little side hustle selling centrifuges. And so he was getting made in China centrifuges, a couple $100 and selling for a couple $1,000. Getting made in China test tube, 50 cents, and selling it for $20 each. And so in order to sell his little made in China test tubes and centrifuges, he would say, well, it's a different product as PRF. And then later he got together with another Moroccan fellow in Boca Raton, Florida. And the Moroccan fellow in Boca Raton, Florida had worked for Imtech, the mini implant company, then started his own mini implant company in Boca Raton. And he was importing a Brazilian mini implant, and he called the company Interlock. So they're selling a Brazilian mini implant. The two Moroccans got together, and they started selling a Brazilian centrifuge, and now they called it LPRF, L for leukocyte, because they said, well, this is a better version to say it's a different centrifuge. Well, that lasted for a few years, and then the two Moroccans had a falling out. So now the Moroccan from Europe, he went back to Europe, and the guy in Boca Raton is very clever. He trademarked, copyrighted the word LPRF. So now this guy went back to Europe. He couldn't use LPRF, even though he'd introduced the whole concept to the mini implant guy. He couldn't use the word LPRF. He had to come up with a new word. That's when he came up with APRF.
Okay.
And at least the P stood for platelets, and the F stood for fibrin, and the L even stood for leukocytes. The A, you know what it stands for? Advanced. This, at least before, is at least scientific words. This is advanced. And now the guy's talking about, oh, I have a new version. I call it SPRF. Like, what's the S for? Super. This is, you can't make this stuff up. It's just so that completely marketing is to sell the new centrifuge. Yeah.
That's awesome.
And there's going to be more, then what people have seen is with changing acronyms that it helps sell centrifuges. And so there's more and more people jumping on this is bandwagon. The first company that made a sort of dedicated spinner, a dedicated centrifuge for this, Harvest Technologies, that's all they had, just a centrifuge. And they sold that company is to a Japanese company for $80 million. And all they had is one product, a centrifuge, $80 million company. Well, of course, now everyone's like, well, I'd like to sell off a centrifuge company for 80 million bucks. And so that's why there's so many different players in the centrifuge market now. In the US, the dental market, there's 40 different centrifuges now. And now this has gone from dental into orthopedic surgery and vet medicine and every surgical specialty. In medicine, there's over 200 different centrifuge companies competing is in the medical, is just in the US alone. What it tells you is such a huge market. It's $50 billion is in PRP things is last year. And so there's enough room for 240 different spinner companies competing for them. Yeah, good question. Other questions? No? So what happens, you get a break in that capillary wall.
Let me just say it for some people that logged on a little late. Go to your chat. Again, this is live. And so if you have a question at all, and again, if it's a good question, which we only got one, and it was a great question, I'll interrupt Arun and make sure your question is answered. So like you said earlier, this is about you. Get the most out of it. And this is your opportunity to ask the founder and ask the expert.
Absolutely. Okay. So you get that break in the capillary wall and the platelets get activated. They get activated is they change their shape, as we talked about. They start clumping together. They trap in the fibrin. So you can see on the slide that about half of that platelet is, let me just get this chat box. How am I? Okay. Is they trap, so it's about a half platelets, about a half fibrin there is in that clot. And then it stops the bleeding there. And of course, some leukocytes, white blood cells get trapped in there. Some red blood cells get trapped in there. And that's why the scab looks kind of reddish or purplish is that forms there. And then slowly what it does is the growth factors that are released is they will then tell the body to heal the area better and faster. And so it's a very clever mechanism is to do that. And so we published our first paper. We started doing this is early 90s, 92, 93. We published our first paper on it in 94. And then in 95 is we did a bone symposium, and it was not meant for the end user. This bone symposium was meant for speakers, guys that are authors or researchers. It was like a mastermind group. And we thought we'd get about 30 people that just want to spend just 3 days just on bone, not even implants, just focusing on bone and kind of, eggheads and so we ended up getting, the chairmen of oral surgery departments, chairmen of peri departments, is book authors and speakers and such. And 300 folks showed up for this meeting at the Breakers Hotel in Palm Beach. And it was our department, University of Miami. That's where I worked for 18 years full-time as a professor. And now I'm in private practice in Miami and co-sponsored by 3i Biomed. And that was the first time that we actually, in addition to publication, in a symposium presented on a PRP. And we talked about it there, and it really got a lot of folks excited at that time. And then we did the symposium again with them, a bone symposium, bone biology, bone grafting for the next century, again, us and 3i in 1997 is with them. And we continue to do that bone symposium, and we continue to this day. We're not sponsored with 3i any longer, it's just us. And so this is our 25th year of the bone symposium. We do it about every other year. And I say about because sometimes like COVID comes along, although it worked out. We did last one in 2019 as we hadn't planned this year and obviously didn't do it. And we have our next one scheduled for, I believe, October 2021. And we bring the greatest minds and greatest techniques is on bone. And then you can see we have a lot of workshops and such is there. And so we've been doing this bone symposium for 25 years now, present at the first bone symposium. We try to do cutting edge and innovative and new and novel types of things at each of these bone symposiums. And then we published on it again after 94 and 1998 is an oral surgery, oral medicine, oral pathology, is a platelet-rich plasma growth factor enhancement for bone grafts. And here our clinical studies show that adding this PRP to graft material, it causes a mineralization half the time, at least is histologically 15 to 30% better bone density. Radiographically, we thought it was about double the bone density. It wasn't quite double, is but 15 to 30% better density, and is double the maturation time, and half the time is we got the same amount of maturation. And at that time, the version we were using was a liquid version, because what happens is as soon as the clot forms, is it begins to release the growth factors immediately. And so it releases the majority of its growth factors in the first 8 hours. It releases them for 10 days, the lifespan of the platelet, but the majority are in the first 8 hours. And the majority of that are really within the first hour and a half, 2 hours. And so what happens is we were doing these big cases like Ruth, there was a 6-hour surgery. And if we had allowed it to clot, then most of the growth factors would be in the Dappen dish, not in the surgical field. So we'd use a liquid version, and to make it liquid, we had anticoagulant in the test tube. This same anticoagulant that every blood bank uses in every hospital, every day in every country. Nothing dangerous about anticoagulant. It's called ACDA, used every country, every hospital, every day in every blood bank. If there was an anticoagulant, then blood banks would not be blood banks, they would be clot banks. So of course, anticoagulant, and that's what we did. And so the anticoagulant is, it's like the EDTA used for the is RC Prep to do a root canal. It binds the calcium. So the ACDA binds the calcium so it doesn't clot. But then when you add it to the surgical area, it gets the calcium from the blood and it does clot. So it doesn't mean that it will never clot. Then it clots once you put it in situ into the surgical area. It doesn't in the test tube. All right. So then the growth factors are released here rather than in the test tube. All right.
Can I interrupt you again here?
Yes.
I know you're on a roll. A couple questions came up.
Yeah.
So someone said, you know, there's so many people that are teaching a certain protocol, and you get hung up on this protocol. Does the centrifuge or the type of centrifuge, does that affect the quality of the PRP?
Is out of the centrifuges that are out there, is they're all essentially is the same. Okay, it would be akin to saying, does the implant motor affect the quality of your implant surgery? Well, you got a good brand name implant motor. There's a bunch of them out there. It should be very similar. I mean, you get off of eBay, it may not be the same. It's like saying, does a handpiece brand affect your crown? Is finally, well, out of the major brands out there, whether you use Cavo or Midwest or some name brand handpiece, I mean, it should be fine. You get one off of eBay and the thing chatters, it won't be the same. Okay. So when you're talking about is quality name brand ones, there's no difference.
Okay. The other question was
favorites. Like you may have your favorite. You may say I prefer Cavo, and someone else may say they prefer Midwest. But it's a quality products, right? So you get quality centrifuge. They're similar.
Okay. The other question was, can the therapy be used for bony defects of a periodontal impacted tooth, like a furcation involvement?
Oh, absolutely. Oh, absolutely. Yeah. I didn't include any of those in today's presentation. But it's in my next book. Is for furcation involvement, because you got to clean it out, of course. You've got to graft it with bone, but you add the PRP to the bone, and we'll talk about making the consistency. I mean, it can literally change that powdered bone in the consistency of a gummy bear candy. And you put that in there, that's going to stay, because you put particulate furcation, it floats all over the place. You put something that consists of gummy bear candy, it's going to stay there and forms bone twice as fast and 15 to 30% denser. Yeah, absolutely. Other questions?
When is your book coming out?
The next one, I just sent to the printer, I mean, literally this week, I mean, 2 days ago. So they don't even have it on the website yet. They'll probably put it on the website in about 3 or 4 months, and sometime in 2021. So that's what I was doing during all those COVID times. I sent them a book that will be released probably January, February, on using it for fillers, dermal fillers, and so I worked on these 2 books when I was home, so I got those turned in. Yeah. So we were using a liquid version, and again, nothing wrong with that. you hear a lot of folks is saying, well, you don't want chemicals in the test tube. That's like, I mean, that's like saying water, H2O is a chemical. That's like saying sodium chloride is salt is a chemical. I mean, it's an anticoagulant. Is I would argue the opposite. I don't want a clotting in the test tube and losing all the growth factors in the test tube. I want it in the surgical site. And so is liquid version actually made sense for long surgeries. And then we published on in 2000, the use of platelet plasma to enhance the success of bone grafts around dental implants. And you can see it for sinus lifts and holding it together here. And then is also in 2000, several of my residents and I, these were my residents, these two fellows, we published on making a membrane out of it. Now, not with an anticoagulant, allowing it to clot. All right, allowing it to clot, taking that clot and compressing it and making a membrane out of it. All right, we simply call this version PRP membrane rather than PRP liquid, as we did. So this is non-anticoagulant. All right, so we talk about both. PRP can be with anticoagulant for liquid version or without anticoagulant for the membrane version. This could be over a socket preservation to hold your bone graft in place. And this is a $2 membrane, unlike the commercial membrane, which is $100. And unlike the commercial membranes, which have no growth factors, this has growth factors in it. So you got a $2 membrane instead of $100 and has growth factors, unlike the commercial membranes. And then as we started a bone symposium in 1995, which we're continuing to this day, so we have our 25-year anniversary on it, is by 2002, there was enough information, enough interest to hold an entire 3-day symposium just on platelet-rich plasma. When we started in 1995, the bone symposium, we thought that was esoteric. Who wants to listen to just bone for 3 days? We thought, again, 30 people would be there. 300 people showed up. And so at first we thought, do people want to spend 3 days just on PRP? And indeed they did. It wasn't 300, it was about 150 folks. Our first symposium on platelet-rich plasma and its growth factors is we held it at Disney World is in 2002 in Orlando. And then have been doing that on a regular basis since then. 2003, we held it in San Francisco at the Fairmont Hotel. Is the second symposium on platelet-rich plasma and its growth factors. Marcus and I were the symposium directors, and we've continued this, and have done this now for nearly 20 years. Is a PRP symposium. We held our last one is right before all this COVID business had started. And then at each of these, we have each of the speakers submit a chapter and we put it together as proceedings. It turns into a textbook from it. And then in 2005, we published on using the gel itself without drying and compressing and make a membrane out of it. And so we used it for crustal sinus lifts. And so one side with bone graft, like you would typically do, one side crustal sinus lift with only PRP gel, letting the clot, taking the clot, chopping up little pieces and shoving little pieces of the clot in there. And we just call that PRP gel. No anticoagulant, obviously, because it was gel, glass test tube, and packed that in there. We found the same result, bilateral split mouth design, and is later folks coming in and they've got the folks on this side that had the bone, the folks on this side that had gel, the same amount of bone formation. And so to this day, is for crustal sinus lifts, I still use just gel. I don't put any bone in there. And it's not a cost issue, it's just a safety issue, because if the gel will either go in or will come back out, it won't pop the sinus membrane. You pack bone in there, it has enough body, it could pop the sinus membrane. So I do it from a safety.
Arun, on average, how many cc's of blood are you drawing for an extraction site, let's say?
Well, is the test tubes are 10 cc's and they got a vacuum in there. So what happens is you don't have to try to make each one the same height. They come with the same amount of vacuum. So when you put it here, it will draw the 10 cc's of blood and will then stop drawing. Then you put another test tube in that same needle, drop the 10 cc's of blood, 10 mLs, and then it will stop drawing. So it is 10 and you have to counterbalance. So in a centrifuge, it may have 8 spots in there, but you got a 2, 4, 6, or 8 in there. Now, in theory, you could have water to counterbalance it, but I prefer to have 2 tubes of blood rather than water, because water is a little bit less dense, so you'd have to have a little bit more than 10. So I have to force a little bit extra is a solution in there, because if the thing doesn't, if it's not is a spinning well, if it's bouncing because it's is the weight is off, it's not going to separate well. And so you've got to make sure. So you say, well, for a socket preservation, it's going to be 2 test tubes of blood.
Okay.
And we'll talk about what we're going to use them for, because one will make a membrane out of it, 2 will make membranes out of, or one will make a membrane out of, and one will use to hydrate the bone.
Okay. So you're not putting you're not putting bone in your crustal list. What about lateral list?
Lateral, I always do, always, because what happens is when they're breathing in and out, the sinus membrane goes up and down. And so crustal, you typically put the implant at the same time. So the implant keeps the sinus membrane elevated up, so it's not going to get compressed, even though all I got is blood clot underneath it. Lateral, you typically don't put the implant at the same time. So if all you had in there was blood clot, with the breathing, it would compress it and you'd end up with no bone. So you got to have something with better density. Right? But otherwise, it is not a function of which side. If you did lateral and place simultaneous implants, you could easily put the PRP gel there as well. It would work just as well. But you got to have something to tent up the sinus membrane. So most often lateral wall is only bone graft. So most often it's got to be with his bone in there.
Okay, good, awesome.
So yeah, is for crustal to this day I put in. And so by 2005, we published this entire textbook, Dental and Craniofacial Applications of Platelet Plasma, Marks and I. It was $98, is I gave you as a way of disclosure that I do get 10% royalties on books. So in this case, it was 10%, it was $98. So we got $9.80 to split between the two of us. So we got $4.95 each. So it wasn't lunch, we each got a cup of coffee every time someone bought a book. But I mean, it did well. I mean, obviously I joke about a cup of coffee. We got thousands of cups of coffee. So and we had a chapter on the biology of platelets and how to develop it, and on bone regeneration for office-based procedures, sinuses and ridges and third molars and perio defects, which you had asked about, and ridge preservations. And then it used for office-based periodontal procedures is free gingival grafts and root coverage procedures, and things like the pinhole techniques and such. And then is some of the things that is more our passion is tumor and trauma defects, mandibular reconstruction and mid-face reconstruction and cleft palate reconstruction. And then is facelifts and is blepharoplasties is using this, and in conjunction with fat grafts. Is taking fat from the gluteal crease and adding the PRP to it is making it better. And then we had an appendix in there for phlebotomy and there. And so that would have had to have been the first generation, which was just the liquid version. And then is by the time that book came out in 2005, we had the liquid version, the gel version with no anticoagulant, the membrane version with no anticoagulant. So 3 different versions. So we could call that second generation. Is today is I would consider 5th generation. And some folks are kind of stuck on second generation. Go, well, we're going to talk about second generation. We're going to talk about gels and membranes, not just liquid. Like, why would you be stuck on second generation? Let's go on to 5th generation. Is like you do with composites. I mean, why would you use a second generation composite today? I mean, what is it? 7th, 8th, 9th generation composites? The first generation might have been self-cure, et cetera. So let's focus on 5th generation protocols, not second generation protocols or not first generation protocols. And in the 5th generation, there are now 7 different versions. The original liquid, then the membrane, then the gel, and now these other versions that we'll talk about. And we'll talk about how to prepare the different versions. We'll talk about is the clinical applications of the different versions. And so let's focus first on just the liquid version. Okay, this had anticoagulant in it. You saw that yellow rubber stopper coming off of it. In the US, yellow rubber stopper, they're called yellow top, is they have an anticoagulant, the same one that blood banks use. And so it's not going to clot. I'm just pulling off the top portion, which is serum or plasma, and I'm discarding it. Right? And I'm going to get this middle portion, and the middle portion is here. And you can see the white blood cells. You see that white line there? So that white line is the white blood cells. And so you're getting right above it as a fibrin, above it as a platelets. Right? I got a little bit of the red blood cells because some of the most robust platelets, they're denser and they end up in the top of the red blood cell layer. So I took a little bit of the red blood cell there to be sure I captured the most robust platelets. And so now we're taking that and hydrating a bone with it instead of with saline, right? Instead of with store water. So we got growth factors there. Is 500% is better than we would have with just blood. Is I would add another test tube because you didn't have an even number. So we could have one yellow top and is across from it, we can have a red top. Red top has nothing in it. And so it will clot. And that's what you do. I take some very fine tweezers, reach in there and grab that clot. And you can see it was the middle layer. Again, the concentrated platelets, concentrated white blood cells, concentrated fibrin, and a little bit of the top red blood cell comes up with it layer because that's where the most robust platelets are. And so this is an older case. I used to just squeeze it between some gauze to make a membrane. Now there's sort of a bit more sophisticated version of making the membrane. And there you go. 50-cent membrane, biologic. And so that would have been a 50-cent test tube here, 50-cent test tube here, $1.50 needle, $2.50. And $2.50, we're able to hydrate the bone with growth factors. And at the same time, we're able to make a membrane to put over that socket preservation. And if we get the assistant trained to do this, then the workflow would be the assistant walks in, she draws the blood, she puts the test tubes in the spinner, she calls the doctor in, the doctor anesthetizes the patient, right? The doctor pulls the tooth, the doctor curettes. By then the spinner has done his thing, the assistant grabs it, right? The doctor pulls up that middle layer and hydrates the bone with it, 60 seconds. The doctor pulls out that middle layer, the clot, squeezes it, 60 seconds. So for the doctor, it's maybe 2 minutes of extra working time. That's it. Because the assistant's the one drawing the blood. She's the one spinning it. She's the one bringing everything is the surgical site. So it really doesn't change the workflow or the time for the doctor at all. All right. And $2.50 is, as you can see here. All right. And now what they have is these kinds of little metallic boxes. You can take this. All right. You take that. You can put several of these. And it's a little lid that goes inside the box rather than on the outside of the box. So it will compress that gel or clot. It's got a plunger here. You put the lid on top of that. That's a weighted lid, and that pushes the plunger down and flattens this and makes a nice, flat, even membrane within several minutes. And the assistant can have this ready for you. She can have the liquid PRP drawn up in a syringe for you. And in our offices, this is what I and all of my associates, this is what is done routinely. There you've got the two membranes. Right. In this case is either we didn't have a liquid one or we would have had 4 test tubes. Right. And that book that I showed you, the platelet-rich plasma, dental and craniofacial applications of platelet-rich plasma, came out in 2005. This is the more recent one, came out in 2018, also from Quintessence Publishing. So the last one from Quintessence Publishing, as is this new one. And so what are the benefits of PRP? At least 6 different known growth factors. And we don't need to go over the names today, and it doesn't matter to you, but a number of different growth factors. And what happens is better osteoconduction because bone cells creep on fibrin. So if I have 500% more fibrin, I will have more highways for bone forming cells. Better stabilization of the hard tissues, better stabilization of the soft tissue. We're going to talk about that and show that. And of course, better hemostasis, less bleeding, less oozing after surgery, less pressure on nerves, causing less pain, less sutures popping open. All right. So if we talk about liquid version as the original version, right? Yellow top, it could be used to hydrate the particulate, as I just showed you. If you had a block graft, you could use it to hydrate a block graft. Right? You could use it to hydrate a collagen membrane. So if you were going to use a commercial collagen membrane, you can get collagen membrane benefit and the growth factor, the PRP benefit. You could literally squirt it into the implant osteotomy before you screw the implant in. So instead of blood at the interface of the bone to the implant, you got PRP at the interface. 500% more is platelets and fibrin at that interface. Better healing there. You could use it for Prp facials. Like, what the heck is that? Well, folks, as they get older, they get the lines and wrinkles because of less collagen. And if collagen can be stimulated to form more, less lines and wrinkles there. And so it'd be a matter of getting PRP to within is into the dermal layer. And so we can talk about that a bit. Right? Whatever device you purchase, and we talked about that, and David asked about different machines, the quality ones, they're going to give you a chart like this. They're going to give you a chart on what speeds and times to make the liquid version, what speeds and times to make the gel version, what speeds and times to make the membrane version, what speeds and times to make the different versions. If they don't have it available or they refuse to give you a chart like this, they're not a quality product. Right? They're probably refusing to give it because they're probably not FDA approved. So this is the first indication. If they give you a chart like this, they're approved and they're a quality product. If they refuse to give you a chart like this, there might just be a lab centrifuge. There might be just is something that's been urine in or something, and they're just selling it. So be very careful of that. Look for companies that give you a chart, specific forms, okay? And so is you draw up the top portion as we talked about. You take the middle portion. We'll call that PRP liquid just because it's more descriptive. Some people call that IPRF, as for injectable PRF. All right. And so you hydrate the bone with it. We took the top of the red blood cell layer because it has the most robust platelets in it, but it does make it look red, bloody. That's okay because this is going to be a bone graft. And so I don't mind that, right? But if I were going to do a PRP facial, then I do mind it. So if for bone grafting, I will take the top of the red blood cell layer. Right? If I'm going to do a PRP facial using liquid, I don't take the top of the red blood cell layer. I forgo some of the most potent platelets, right? But in the interest of the patient leaving without a big bloody face there. Right? You could take that PRP liquid and hydrate a membrane in it. Right? That's a collagen membrane. You hydrate that. Now you get the collagen membrane benefit and the growth factor benefit. Right? So you take your 4-month membrane, you soak it, you get both benefits. Right? That's why I like the collagen membranes. I don't like the PTFE membranes, the Gore-Tex type of membranes. Right? Because number one, I got to come back and take them out. Extra surgery that I don't get paid for. So it's a hassle for me. Hassle for the patient. Extra surgery you got to come back for and get cut for. And it doesn't absorb the PRP or blood. And
hey,
so
Arun,
Arun,
again, I'm going to interrupt you here. Someone asked, how long does the PRP last within the site? How long does it remain active?
It's for 10 days.
Oh, 10 days. Okay.
10 days, yeah. So it can work as for socket preservation to prevent things from coming out because by then you have epithelialization of the mucosa. If you're missing a buccal wall, you don't need a 10-day membrane. You need a true 3-month membrane. Okay. So then this wouldn't suffice. So this is membrane in certain applications, but not in every application. Okay, and that's where you would use the commercial membrane, but hydrate it in the PRP. Right? Yeah. So there's applications for each. So the way to get this in, because the problem is the skin is meant to keep things out. Right? Otherwise, every time you touch something, you get all the bacteria and such into your system. So skin is meant to keep things out. So folks buy all these potions and things and creams for the face, but it doesn't help much because it doesn't get to the inside where it needs to do its work. And so to get inside, we get these dermal rollers. They're $15 a piece. So I put topical on the face for about 15 minutes and then non-flavored. I don't use the pina colada flavor in the face, and non-flavored, and then wipe it off and then dermal roll. And you can see all those little needles that are on there. They come in different lengths. Is the ones I like is 1 or 1.5 millimeter. I want to get past the epidermis into the dermal layer. This is too deep, right? This is too shallow. Some of the ones from like rodent fields for folks to just do themselves, consumers to do themselves, they're like 0.2 and 0.3. They're for consumers or without topical, just getting the epidermis layer. It's still some value. There's nothing wrong with that. Still some value, but the maximum value we want is with topical and the 1 to 1.5 millimeter rollers. And they will make up to 200 punctures per square inch. And so roll that over. And then once I've rolled it, I've drawn up the middle layer here, as you can see, wiped off the topical and then roll punctures, 200 punctures per square inch. All right. And now just spray that PRP liquid and smear it on there. It's like putting face cream on. I'm literally like putting face cream on for the patient. but it's now getting 1 millimeter into the skin into 4,000 of these micropunctures. And they close up within a half hour, right? But now the growth factors have gotten in there into thousands of micropunctures in there. That's what it's done. You say, well, if it works on the skin, can it work on hair? And indeed it can. Hundreds of publications out there that it works on hair. And so it would be rollers. It can be done, but rollers for just folks that have short hair, because otherwise with long hair, it catches up in the roller. And so short hair can be roller. With longer hair, what I do is I inject and bam, 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 bam. What happens is a third of our hair is growing at a time. And so that's the ones we need to work on. Now, we don't know which third it is. We're injecting all of it, but it's only helping a third. And so, and then 7 weeks later, different third is cycles in the growth phase. And 7 weeks later, different third cycles in the growth phase. So it's 3 treatments, 7 weeks apart. And so is if it's very short hair, then we can use the rollers. If it's longer hair, then I'm injecting at the follicles. I'm injecting the follicles. All right. And so is liquid can be used, as we said, to hydrate bone. It can be used to hydrate membranes. It can be in implant osteotomies. It can be used for rollers. It can be to inject in hair follicles. Here's another case, hydrating the bone for a lateral wall sinus lift. I make a mid-crustal incision here. And then is a vertical release is take a number 8 round burr and make an oval osteotomy. You can see bone color, non-bone color. And as soon as I start getting the non-bone color, I know I'm through and close and approximating the sinus membrane. And then I just peel off the little island of bone. I peel that off. I take the tissue bank bone. This is freeze-dried tissue bank bone, hydrated with PRP liquid. And then once I've done that, I take that sinus membrane with curettes, gently curette and lift that up, is out of the way. Right? And then we're going to pack bone in underneath this. So we take this bone that might have been 4 or 5 millimeters and grow it to 10, 12, 15 millimeters, whatever size implant you're planning to place. And so I take this freeze-dried bone, hydrated in the PRP liquid, pack it in there. And once I've packed all the nooks and crannies and gotten it in there, I take a membrane, the 4-month membrane, hydrate it in the PRP, and then put it over the lateral window, and then suture it closed. All right. So a number of different ways for the liquid version. All right. And if we're okay, then we'll keep going on to the gel version. For the gel version, really 2 primary functions, right? In dentistry and in other medical specialties, really almost no benefit from this. You know, as David had mentioned that, you know, orthopedic surgeon might be on, others might be on. For orthopedic surgery, what are you going to inject into the joint? Liquid version. You're not going to inject clots into the joint. You're not going to inject membranes in the joint. It's going to be liquid version. So in most other specialties, it is liquid version. Is the PRP gel. It can be used for crustal sinus lifts, we already talked about, and it can be used for third molar sockets. All right, you extract a third molar. You say, well, I'm not going to do a socket preservation on a third molar, and indeed, you may not need to, and that's fine. All right, you say, I'm going to take that third molar out, but when it's $2, none of your time, 2 minutes of your time, why not take this super clot and put it in there? Because the studies show less incidence of dry sockets when this is placed in there versus not placed in there. They did split mouth design in these studies. One side got PRP gel, one side got nothing. The side with PRP gel, significantly lower incidence of dry sockets. It makes sense. A significantly lower incidence of defects on the distal of second molar, because sometimes when you got this impacted third molar hitting up on the distal of that, you lose some bone on the distal of it. Less. Lower probing depths on the distal of that second is a molar. So less loss is here. Better healing is less swelling, less pain, and less dry sockets there. And so it just makes sense if it's just a couple of minutes to do this and just a couple of dollars. I mean, the question I would always have is if this came in a bottle for $2, would we put it in every single third molar socket? And I think most of them would say yes. Right? So why don't we? Well, we may not know about it, but the other thing is the blood draw. It doesn't come in a bottle, the blood draw. So I would say instead of you or I doing the blood draw, have the assistant do it, because our time, we can generate hundreds of dollars per hour. Whereas the assistant's time is worth whatever, 20, 25, 30 bucks an hour. And so have the assistant do it. All right. So she's the one that's doing this. All right. For crustal sinus lifts, make an incision slightly palatal, reflect the flap to the buccal, And then we're going to make our osteotomy just up to the sinus floor without perforating the sinus membrane. I'm using drill stops to be sure I don't go too deep. And then what we're going to do is take that PRP gel, cut it into little pieces, 2 to 4 millimeters across. And with a condenser, with a drill stop again on it, so I don't over condense, I don't go in and pop the sinus membrane inadvertently, is we're going to put these little pieces in. Carry that little piece of gel there, and then condense it. Carry the piece of gel there, and then condense it. All right? That's what we're going to do. All right? And when you do that, is that piece of gel will either elevate the sinus membrane, all right? It's just going to slime up underneath it, or it's going to come back out. It doesn't have enough body or strength to pop that sinus membrane. So I like it better than bone, not only the cost savings. I mean, obviously I'm not putting $20, $30, $40, $100 of bone in there, but the more important thing is it's much safer. And God forbid, if you did get a little pinpoint tear up in there, you already got a PRP gel to patch it. And so just much, much safer. And then putting the implant in, because you do have to, when you use gel alone, you do need something to tent up the sinus membrane. And so putting the implant simultaneously, putting the cover screw on, and then suturing it closed. And there it is, sutured closed. And so this is something that can be done all day long. As you take these cases, which everyone has in their office, that might have 6 or 7 or 8 millimeters of bone, and you need a bit more for a 10 or 11 millimeter implant. And what's called, a lot of folks call it sinus bump. And so is all of you listening are capable of doing this sinus bump. Is they have the assistant draw the blood, make the PRP gel for you, is go through, is elevate, and there's kits available to do this. There's very, very reasonably priced kits to do this. And so you do that, put the implant in. All right. Any questions on this? All right, I'll check real quick here.
There is one question. Someone asked if there's an active infection, does the PRP interact with that? Is there an issue using the PRP in conjunction with antibiotics?
That's a great question. I'm just getting this thing out of the way. Great question about is PRP is with an infection. If you pull a tooth, you got an infection there, and you pull the tooth, and what do you expect to help fight that infection after you pull the tooth?
White blood.
The blood. I mean, you expect the blood to. You expect the platelets and white blood cells to, right? Okay. So if I put in 500% more white blood cells into that, oh, that would actually do better, wouldn't it? Okay. That's not to say we pull a tooth, we should leave a bunch of pus in there. No, no, no. We're going to do our best to clean it all out. Okay. But once you clean it all out, is it better to put a PRP clot in there or let a normal clot happen in there? And of course, I think all of us would agree a super clot is going to be much better to fight that off, whatever residual infection that might be there, rather than a normal clot. And so absolutely, PRP is not only okay in infected sites, it is better than a normal clot in infected sites.
Can you repair sinus perforation with the PRP?
Oh, absolutely. So here's what happens, is we said the PRP membrane lasts 10 days. So if there's a perforation that sinus membrane as I'm elevating, that's between 0 to 3 millimeters across, the body's going to heal itself, but 0 to 3 millimeters will heal in about a week. So if I take a PRP membrane, hold it near that hole, tell the patient, breathe in through the nose. And as I breathe in through the nose, a negative suction, it creates that negative suction. I let go of the PRP membrane, it just flies up and sticks to that hole. It's going to heal. This is going to is dissolve in that 10 days. But if it's bigger than that, you got a 5, 10, 15 millimeter tear, it's not going to heal in a week. It's going to take about a month to heal. So then I need a commercial membrane. Same thing, take a big piece, hold it near there, let them breathe in. And it's better if I dip that commercial membrane in PRP first, so it sticks better. Growth factors and sticks better. But then if it's more than 3 millimeters, commercial membrane, spend the $100, soaked in PRP, even better, growth factors, sticks better. If it's more than 15 millimeters across, then it's hard to stabilize a patch. I mean, what do you patch it to? So if it's larger than that, then what I do is I take, from the tissue bank, I buy these sheets. It's a sheet of bone. And they take a sheet of bone, they lightly demineralize it, so a little bit flexible. I pack that in there and make a new roof, a bony roof, and pack underneath it. And so that's the 3 ways. Easy, small tears, PRP membrane. Medium tears, collagen membranes, is large tears or complete obliteration is a sheet of bone from the tissue bank to make a new roof. Yeah, let me keep going. Yeah, great question. Okay, so if we take that gel, and as I'd shown you earlier, you compress it, and you can make a PRP membrane out of it. And that PRP membrane can be used for socket grafting, or as we said, is to tear for a torn sinus membrane within certain parameters, right? Not the super large ones. It can even be used as a coverage over that lateral window, as it doesn't have to be a commercial membrane there. It can be used over block grafts. It can be used for things like gingival recession, is you harvest some connective tissue from the palate, as you could fill that area with PRP instead of a normal clot, as you could inject in the liquid into the hole, we said, but at uncovering, when we take the cover screw out and we're going to put the healing cuff in, we could take a PRP membrane, punch a hole in it, almost like a poncho, and then screw the healing cuff in. So this poncho of is growth factors in that area to allow for the best healing of, if we reflected the flap of the bone and the soft tissue maturation there. And so a little poncho is there. So it's going to be a 10-day membrane. It's good for containment. It's good for more growth factors. Where I need a longer lasting membrane, 4 months, then of course we will still use commercial membranes. It won't completely take their place. And so still indication for that. And for this is taking this, is putting it in this little box, is putting that lid on there, is you put the lid on top of that. It takes that plunger and pushes down the plunger, flattens it out, makes a nice and even 1 millimeter across. And so you get nice large 1 millimeter membranes like this. Right? Whereas when I used to squeeze in gauze, they were kind of uneven, depends on where I squeezed and how much I squeezed, and I didn't get quite as large of a membrane. Right? Where's the most robust platelets? We said in that top of the red blood cell layer. Right? So my best platelets are there. So when I've got a membrane like this, the area that I want the best growth factors is the side I'm going to put the reddish side on. Right? Right? And this is how strong it is. I mean, one day, because I do 2, 4, or 6, I had an extra one. So I asked the staff, I said, get me a hemostat. So I grabbed the top of it with a needle holder and I hung a hemostat on it. This is a 50-cent membrane. And then I said, wow, this is great. Get me more. And they gave me a second hemostat. And I hung that on there, third hemostat. And I thought I was going to run out of room. I thought, like the game you played as a kid, those hanging monkeys. I thought I had to hang the hemostats on the hemostats. But so far, so good. And I'm yelling at them, hurry up, get me more hemostats. And then running on the back, 4 hemostats. This is a biologic 50-cent membrane, 5 hemostats. I'm screaming for more hemostats because none of this was planned. This is just an iPhone video here. 6 hemostats. And we finally ran out at 6 hemostats. So I said, okay, let me try this. Boing. Let me try this, spinning it. So that's the texture and the strength of this biologic 50-cent membrane. And so all of these different applications you can use it for. And the workflow is the assistant does it. She draws the blood, she puts in a spinner, she takes it out, she puts it in a box to make the membrane for you. You come in and do your normal workflow. Just a couple others. We're going to
Can I interrupt you again?
Of course.
Someone asked, do you use a pericardial membrane for the superior aspect against the membrane prior to the graft in the lateral sinus technique?
Great question. Okay. So for those that may not be familiar, pericardium is the surrounding of the heart. And so it's from the tissue bank, and they don't get many of them. I mean, you can imagine, bone, you crush up the skeleton, you get a lot of bottles of bone, but you take a heart and you take the surrounding of it. And so you get only a few pieces. So it's tough to get. But it's a nice collagen membrane. If it can put up with 60 beats a minute, it's a tough collagen membrane. And so it has about a 4-month resorption time. And so to routinely put a membrane inside the sinus, up against that sinus membrane, to me, I don't, and it's not a cost issue, although it would add substantially to the cost. I mean, it's $200 membrane. It would add substantially to the cost. But biologically, it just doesn't make sense to me to add a membrane in there when I don't need it. And so it's from a sense point of view, from no studies to show that it's better healing that way. From my time point of view, yeah, a little bit, the $200 for every procedure point of view. So I don't do it routinely. I suppose if I worked for the tissue bank, I would say, yes, use it routinely. One inside, one outside, one on the left side, one on the right side, get 4 of them. I've heard is oftentimes sponsored speakers saying things like that, because the more membranes, the merrier. But so you might have heard sponsored speakers talking about it, but folks that have no sponsors and just believe in biology or the research or the data, as we don't talk about putting membranes in, and we don't do it as there. And actually is the membranes, the collagen membranes, a lot of them out there on the market, is the one I use now is something called Osteoflex. It's not a pericardium, it's the peritoneum. It's the lining between the skin and the organs, and it's porcine derived. And I've seen that it is excellent handling and excellent resorption time, and is not as short a supply, because as the pericardium around the heart, which is what I use for years, it's just tough to get. And because it's tough to get, the price just keeps skyrocketing on it. And so now I use this porcine derived peritoneum, works just as well. And so is even if I did have to put something inside for a tear, that's what I would use. But whatever.
Someone already also asked, if the person is diabetic, does that affect the healing factor with the PRP? Are you seeing?
Well, I guess the bigger question is, does a diabetic heal slower in general? I mean, not about the PRP. Does it heal slower in general? Of course, they do heal slower in general. So do we need to give them something to heal faster? Of course. I mean, that's who I would give the PRP to. Is if I'm putting implants in the anterior mandible in a 25-year-old, do I need to squirt PRP in that hole to put it in there? I mean, I could, but that 25-year-old in the anterior mandible, his implants are going to take it. I probably don't need it. Okay. But what if it's a 75-year-old? Should I squirt some PRP? Of course I should. What about instead of anterior mandible, it's posterior maxilla and a styrofoam bone in a 75-year-old? Should I put it in? Of course I should. What if it's a diabetic patient? Should I put some growth factors in? Of course I should. What if it's a smoker? Should I give them growth factors? Of course I should. What if it's a 75-year-old posterior maxilla smoking diabetic? Absolutely gets the PRP. Okay. So the poorer their potential healing is going to be based on age, based on smoking, based on is any of these things, the more chance that I need to use the PRP. I could use it on everything, of course. All right. But so for diabetic, is it something wrong? No, it's the opposite. There's something right. I mean, that's exactly the kind of patient. That's exactly the person whose wounds you don't want opening up. And so we need to have less swelling for those patients. Yep. We need to have things glued down better for those patients. We need to have less faster healing for those patients. As normally they're slower healers to get them back to normal like the rest of everyone else. So they need even more. And the interesting thing is you don't have patients saying no. I mean, you walk in and the system goes, okay, I'm going to draw a little blood. We take about 2% of what you would give a normal blood donation. And then we spin it and collect the molecules that tell your bone to heal twice as fast and be about twice as dense. And the patients go, okay, fine. They put their arm out. And, I think sometimes dentists think that they'll get resistance on it, because I think dentists forget that in the patient's eyes, dentists are doctors. And so they are fully okay with that. I don't think it's a patient that have an issue thinking of the dentist as a doctor, as someone trained and qualified and normal to draw blood. There is some of that, I think, comes from the dentists themselves. So folks that start doing it, I've never gotten feedback that says that they got resistance from the patient on acceptances for it.
Arun, someone asked about coding and billing. How are you billing this? Is there ADA code for this?
There isn't. And when I was when we were first doing it at the university, as we first started this, we used to charge $400 for it. And after we'd sold them a sinus lift or the surgery, and there's a procedure we do that's PRP, and it makes the bone twice as dense and mature twice as fast. That's gonna be $400. Is that something we want to do today? And you never had someone say, nah, I think I'd rather stick with the slower, crummier bone and keep my money in my wallet. So I always said yes. But then later when I got in private practice, I started at $400 and then I brought it down to $200. And today I don't charge for it. I mean, it's just part of the procedure. So if I'm charging for socket preservation, $395, it's built in. If I'm charging for sinus, the $4,500 is built in. I don't itemize it. And I know with insurance, it's good to, itemize things. You have to, otherwise, it's hard to make a living with insurance anyway. So, you charge for the composite, you charge for the decal, you charge for the copalite. I know there's no copalite. Okay.
We don't use that anymore.
Yeah, I know. I know. But you unbundle everything and you got to charge for all of it. But the procedures you're using PRP for are usually fee-for-service procedures.
Mhm.
So you don't need to unbundle. In fact, the opposite. It's easier for patients to understand when you just bundle it. Total fee is this, and includes this. So it's a bundled fee, and so as you don't need a code for it. There's no billable code for it, but your cost is $2, and your assistant, a little bit of your assistant's time. So I don't think we need to stress too much to make it a profit center. Let's make the procedure the profit center.
Yeah.
But good question. Yeah, good question.
Yeah. And, I thought it was really cool when, I did that symposium down there, first one in Chicago,
Right.
and you had the phlebotomy course right next door. And it's like, yeah, I mean, so when I was in dental school at UCLA, we had to draw blood on all new patients. Right. We were looking for diabetes and we were looking for venereal diseases and, HIV just came out. But since that time,
SMAC 20, yes.
Yeah, I mean, we never drew blood after that, in private practice. And I think the one thing that I think really added to your courses was that phlebotomy course. And when you see either dental assistants, hygienists, or the doctors in there drawing blood for the first time, and how easy it is, and that's a real adjunct to your courses. I just want to let you know.
Thanks. Yeah. So if we continue on, there's a couple more versions now that with the 5th generation, you're no longer doing 2nd generation, is PRP exudate. That would be the drippings when we make that membrane in that box. But see, what does a membrane have in it? It's got all the platelets. What else does it have in it? It's got all the fibrin. So what do the drippings have in it? Nothing. I mean, not really much. So we could use it to hydrate the bone, but it's not as good as using PRP liquid to hydrate the bone. We could use it to irrigate out the implant osteotomy. I mean, that's where it might be useful because it's certainly better than irrigating it out with saline a little bit. Okay, it's got some growth factors because as that platelet started to clot, it released the growth factors that are in the drippings. So I could pull up those drippings, right? Just draw it up with a monoject syringe. I've made the membranes here. You got the drippings here, pull up the monoject syringe and flush this out instead of with saline, okay? So not a lot of applications for the PRP exudate, but you got it, a little bit better upregulated from saline. You could use it for that, all right? Another one that we don't need to spend a lot of time talking about, what I'm just calling PRP Plug. And you say, what the heck is a PRP Plug for socket grafting? We took that PRP gel and put it in the 3rd molar area, but it's really very, very soft, very, very loose. If I wanted to give it a better density, I could make it about 4 times as dense, all right? And in that socket, what do I want to do? Here, we said 3rd molar, I might be okay with just gel. But here, anterior, I need bone in there. Just gel is not going to give me bone as predictably. That needs to be freeze-dried bone in there. So that's going to be bone, hydrated with our PRP liquid, all right? In this particular case, on this tooth was a large cyst up in here. And the cyst was actually about 4 or 5 times the size of that extraction socket. You can see up in there. You see just that big, empty, black cavern in there. All right. That was about 2 cc's cavern in there. Well, the socket, I have to put freeze-dried bone here to grow it. That cyst, I nucleated it through here. All right. Cysts, for some strange reason, will fill in automatically with bone. They're genetically pre-programmed. Once they're nucleated, the body will fill it in with bone automatically without socket preservation into it. So I could waste 2 or 3 cc's of the bone. A cc of bone is about $65, $75. So 2 or 3 cc's is about $200 a bone. I could put $200 a bone in that cyst and then do the bone graft I need and that socket preservation there. All right. But that's a waste. I don't need it up in there. I'd like to just graft that socket preservation area, but that's of course impossible to do because it's going to fall into that big empty cavern. So what I do is, and if I put the PRP gel in there, that's so soft, as I put my graft material here, it's going to fall into that gel also. So I'm going to lose bone, a couple $100 worth. So I take the gel, I compress it, make it about 4 times as dense these PRP plugs, I'll show you how to make in a second. I shove those PRP plugs up in that cyst. Now, instead of $200 worth, I put them at $3 worth. They're up in there. And now in the socket, of course, I need bone, so I put bone. All right. So how do I make those? They're just going to occupy space, those PRP plugs. Nominal cost, biologic, have growth factors. As part of that box, there's like a little Jello mold portion here. In that Jello mold portion, I put the PRP gel, take this plunger and put it on top. And once you put a plunger on top, it compresses it about 1/4 the size. So it takes that PRP gel, makes it 1/4 the size, but 4 times as dense. I pack those plugs up in there, right, that big cavern, and then just put my bone just in the socket preservation area. And thereby, I'm only using about $20 worth of freeze-dried bone instead of $220 worth of freeze-dried bone. All right. So it's worth talking about. It may not be worth talking a lot about. All right. But it's worth talking about. This is the one we really got to spend a little time on. What I call gummy bone or sticky bone. Right. And so is in this case, I actually trademarked the word is, Garg sticky bone is actually trademarked word. It doesn't matter to me if you want to use it, anyone can use it. But we just kind of goof around and did that. But I call it gummy bone sometimes because more descriptive, because like the consistency of a gummy bear candy. All right. My original term for it was sticky bone, but I use the two terms interchangeably. This you're going to use to graft ridges. Okay, graft is. So here what we're going to do is we're going to use a shorter spin cycle. We're not going to spin it. You might have seen on those charts, it's usually about 7, 8, 9, 10 minutes. We're only going to spin it 3 minutes. Red top test tube, so it's going to clot. But in 3 minutes, we don't give it enough time to clot. So it's about to clot. All right, we're going to stop the spin at 3 minutes and take out the middle layer with a syringe, pre-clotted. So at a pre-colloidal stage, okay? And so we can add that to our tissue bank bone, the particulate bone. There's another material that I like these days where at the tissue bank, they take like bone shavings and they compress it. It's like a cotton ball. And so it's not bone particles, it's like cotton ball of bone. And it actually absorbs the PRP even better. But either one, tissue bank bone or that material they call fluff, spin that PRP, red top, no anticoagulant, so it's going to clot 3 minutes. Quickly get that middle layer, which is the concentrated platelets, concentrated fibrin, concentrated white blood cells, and hydrate the particulate or the fluff with that middle layer. And just let it sit on the side for 10 to 15 minutes to complete its clotting. But now it's completing clotting not in the test tube, but after hydrating the materials. It ends up like a gummy bear consistency. Right? That's how it ends up. So you got to watch it closely. You see 3 minutes here, 2,800 RPMs. We drop the middle layer quickly, right? Pulling that off, hydrate the bone, right? And you can't be jabbing it because jabbing is like with Jello. If you had Jello, you kept jabbing it, it would never set up, right? So you can just let it sit on the side, right? With Jello, actually got to refrigerate. It sets up better if it's refrigerated. With this, with the blood, actually warmer sets up better. So you don't want it directly under air conditioning vent, for example. So I actually just cover up some gauze. So even if there is air conditioning, it doesn't get on it. So I just cover it up with some gauze and kind of like a blanket. Okay. And so keep it warm. Is glass dappen dish, right? Better than metal, right? Because it'll help the clotting and it won't get as cold. So glass is preferable. Warm is preferable. Right. In this case, I'm using metal. That's just what I have because I don't have the glass, but most of you have glass dappen dishes and you just sterilize them, you autoclave them. And after you're leaving sitting 10 to 15 minutes, this is bone powder 15 minutes ago. And look at the consistency now. 15 minutes ago, that was bone powder. And now it is literally the consistency of a gummy bear candy. You can take this, you can cut it, you can roll it up. You can roll it up and stick it in a socket. It's not going to go anywhere. You take that and stick it in a socket and put a PRP membrane over it, definitely not going anywhere. And what did it cost? 2 test tubes, right? $2. You see, cutting with scissors, that was powder 15 minutes ago.
Arun, let me ask a question since we're watching this. This is very cool. Would the PRP help in the treatment of osteoradionecrosis?
It does. Yeah, and numerous studies, and we use it routinely for that. Yeah.
Are you using the sticky bone, or once you curate that area out?
We would just do, because is for osteoradionecrosis is usually bigger cases. We debride so much bone, so it wouldn't necessarily make the sticky bone consistency. We just use liquid. Yeah.
Okay.
But you see that, you put that in the socket.
That's very cool.
With that consistency, in this case, I want a ridge augmentation here. A couple missing teeth. I make the flap. Okay. I make decortications to get bleeding points, right? Okay. So all of you know this. And now here, instead of bone from the tissue bank, I'm going to take some autologous bone. Okay. Just to kind of show you different techniques. I make an incision around the necks of the teeth. Make a little incision here, just like if you're going to extract the third molar or something. And now from here, take a bone scraper. And this little scraper has got a sharp blade here. Just scraping it for less than 5 minutes, you end up with this 2 cc's of autologous bone. Right? And everybody can do this. This is not going to hip or ramus or chin. This is bone scrapings. All right. Taking these bone scrapings, drawing our blood, red top test tube, spinning it for only 3 minutes, getting the middle layer and hydrating it, and letting it sit 15 minutes. And once it sits for 15 minutes, we know the consistency it's going to have. It's going to be the consistency of gummy bear candy, right? Remember I told you the tissue bank, they will make sheets of bone. So this is a sheet of bone that they made. They lightly demineralized it, so it's flexible. So it took some of the mineral out. What they actually did is they drilled a hole here, 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 6 holes. Same thing over here, 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 6 holes. Now, we're not going to use all 6 of them. We're going to take 1 hole from here, 1 hole from here, and put a screw in it. And if you look at it from an occlusal view, all right, there's a root eminence of this tooth. There's a root eminence of this tooth. If you take this plate, all right, this matrix band, I mean, what every dentist uses every single day, matrix bands, all right? And it started as Toffemeyer, the stainless steel matrix bands, and then went to clear matrix bands. I use composites, and now it's bone matrix bands for bone, all right? And so what's going to hold this up? Well, the root eminence here and the root eminence here, and a screw here and a screw here. The screw becomes the Toffemeyer, all right? And so 1 screw here, 1 screw here. Everybody here can do this. This comes a tissue bank, pre-drilled. You put 1 screw here, 1 screw here, all right? There's your matrix band, all right? Same concept as a clear matrix band for composite, same concept as the stainless steel matrix band for amalgams is bone matrix band for bone. And now we'll take that sticky bone, grab some tweezers, because you can grab a gummy bear candy with tweezers and pack it in there. We had the bleeding points. We packed this in there. We need some PRP membrane for containment, because on top, so we put the PRP membranes on top for containment. There they are for containment. And then we got advance the flap and get primary closure, also for containment. Advance the flap and get primary closure is for containment there. All right. So now what used to be so difficult, I mean, you probably heard folks talking about, well, I take a block of chin bone, I take a block of ramus bone, and I screw it in there. And some of you might have thought, well, I'm not going to do that on a patient. I'm going to send that case out. But now this, you go, well, if I can buy the matrix band and I can buy a scraper to get the bone scrape and my assistant can draw the blood. Well, now you take things that before seemed so esoteric or so undoable and say, okay, this is something that can become routine and doable is for you and your patients and predictable. So this gummy bone is really something I think you can use routinely. Is a lot of different applications. And then the final version, and we'll finish up with this, is PRP with heated proteins, or let's call it biofiller. Okay, I don't have it listed here. That's going to be yellow top test tube again. That's going to be anticoagulant. Okay. So here's what happens. That middle layer is the good stuff. That's where the growth factors are. All right. The top part we've been discarding. That's just the serum or the plasma. We've been discarding it. All right. We said the platelets last 10 days. So as growth factors are great. I did the dermal rollers, greatest growth factor. But if I were to inject them, if you got like as we age, we end up with a groove here because it used to be flat as age into groove. And you put a filler in there, And if it's PRP, it's only going to be there for 10 days. I mean, I call it the Cinderella effect because like it's over by midnight. It's over by midnight in 10 days. So if you use this as a filler, it doesn't work. Things like Restylane, Juvederm, they work as a filler. They're hyaluronic acid. They're there for about 6 months, right? And they will help fill these types of things in, all right? Well, what happens is you take this top portion, you heat it, and like an egg, you cook it, you take the liquid part, the white part, the albumin, the protein, you heat it, and that liquid becomes a solid. So if you take this and heat it 75 degrees for 10 minutes, and there's ovens, $500, $1,000 to get an oven, that's it. And so you put it in there precisely made with that timer, with 75 degrees, this 10-minute timer, it will take this and thicken it. But the important thing is not that this fact is thickened. What studies shows that thickened version will last in the dermis for 6 months, just like Juvederm Restylane. And Juvederm Restylane, 2 syringes are $600. Here, this is $2 instead of $600. And if you need nasolabial folds, that's usually 2 syringes. You need submental crease, 1 syringe. You need marionette lines, 2 syringes. You need higher cheekbones, 2 syringes. I mean, that could be, what was that, 7 syringes right there? Right, $300 a syringe. That's $2,100 just in product cost. And then the injector, she's going to charge $1,000. That's $3,100. And you can get the same results with just $1,000 through the injector and nominal, no cost of product. So it takes that $3,100 procedure, brings it down to $1,000, and a better product is biologic, nothing foreign there at all. Now, if you injected just this, it's going to last for the 6 months, but it won't help fix the problem. You add the middle layer to it, it will actually help fix the problem. So you get the best of both worlds. So if you take just the top portion, it will act like the Juvederm Restylane. You mix with the middle layer, then you actually have, it acts like Juvederm Restylane and helps fix the underlying problem. So instead of $600 for 2 syringes, it's $2 for 2 syringes, and biologic and natural, and lasts the similar time period as there. And so you take these faces and start eliminating some of these things. Right? And folks love it because it's from themselves. It's very, very convenient. It's completely natural because some patients say, I don't want, foreign things injected in my face. And for you and I, it's very, very cost effective. And so now you can either pass the savings on to the patient, or you can charge the same and make a much higher profit for yourself. And so I've got a book coming out on this. And now patients will bring in pictures like this. I want to go from here and to look like I did when I was 20, and so what I've done is put together pictures like that in the book. And I tell patients, look, we can do 1 notch. So if you're here, I can get you to here. If you're here, I can get you here. If you're here, I can get you here. I can't get you more than 1 notch with fillers. And so I show them this so they know up front about what to expect. And you see this is filler. You can see this is much thicker than the PRP liquid. You can see it looks like egg, creamy. And so inject and give the high cheekbones that they used to have. Or lips. And here plumping up the lips, because a lot of folks like bigger lips. And these days, everyone seems to like chins. Like chin is in. And so plumping up chins, as they do. So yeah, this is the book I submitted to Quintessence Publishing about, I'd say about 3 months ago. During all this COVID times, we finished it up. My co-author, Renata Rossi from Brazil. And it should be coming out by about January, so they'll be taking orders on this. Okay, so I've gone over all 7 versions. The 5th generation, I told you what was 1st generation with just liquid. 2nd generation with liquids and gels and membranes is, I wouldn't focus on any of those generations. I would focus on the 7th generation. And during that time, even the liquid version that we do today is different than the liquid version we did back then, because we've modified the speeds a little bit and the times a little bit over time, as we've just seen that we can get speeds and times a little bit improved. Here's my contact information, my phone number. That's my direct cell. It comes directly to me, nobody else. So I'm not good about answering the phone when I don't recognize the number, but text messages. So if you want to take a picture of that, you're welcome to send me text messages. Or if you tell me who you are and you're going to call me, I'll pick up the phone, of course. My direct email address, arun.implantseminars@gmail.com. I've got 4 offices in the South Florida area. So here's the phone numbers. If you're ever in South Florida, I operate. I see patients 4 days a week. So come in and you're welcome to watch me operate. I've got 12 associates between the 4 offices. So even if I don't have something interesting going on, one of them will have something interesting going on. And then of course we have the office in Phoenix, which is, and then we have the office in Santo Domingo as well.
Cool.
Any other questions?
That was awesome. I mean, it was really awesome.
Okay.
Yeah, there are some questions. So one was, what's your preferred bone plate?
Just see it. What's the preferred bone plate? If they want a brand name, it's from Osteolife Biomedical. That's the name, and the website is osteolifebiomedical.com. And I just call Flexo Plate. So that bone plate I showed, I just call Flexo Plate there. And it's really, I don't know if it's the preferred, it's the only bone plate out there because they patented it.
Okay. This is kind of a long question. I'll just read it. This came up in the question and answer section versus the chat. So what is the efficacy with respect to clinical, radiographic, and patient-centered outcomes of combinations of PRP with other therapeutic bioactive agents procedures? Compare with the efficacy of the same agents without the PRP.
It sounds kind of general. I'm not sure, which agents is necessarily they're talking about. But most studies looking at PRP in conjunction with whatever has shown an improvement. So, kind of generic question, kind of generic answer. If you look at, if you use BioOS for something, BioOS and PRP, it was improved. If you used Gen Matrix for something, Gen Matrix and PRP was better. Freeze-dried bone and PRP was better. Autologous bone and PRP was better. Is exosomes and PRP is better. Is stem cells and PRP is better. And so is all of these common things that are out there, study after study shows adding the PRP upregulate. Some gets upregulated more, some less. Is autologous bone gets upregulated 50%. Freeze-dried bone gets upregulated 50%. BioOS gets upregulated 15%. But all the things out there get upregulated.
That was really awesome. I can do a plug for you that you obviously can't as much, but I will tell you, your courses are absolutely incredible. For those that want to do live, how to place implants, how to do surgery, I can't stress it enough. Tell you kind of interesting story. I mentioned in the beginning that Arun and I did combination course down there. I was running an anterior veneer live patient course, and he was doing a surgical course. And so we shared our graduation dinner. So we hired a big boss and went to this great restaurant. And I was sitting next to a woman, a young woman in her 20s, and she was from Iowa. And I said, are you here with the surgical course? And she goes, yeah, I got to place implants. And this is only her second day into this. And I said, you ever placed an implant before? And she said, no, never. I said, how many did you get to place in the last 2 days? She said, 52. 52. It's like, what? I mean, there's people that haven't put 52 in a lifetime. And, she said, last night I stayed till 10 p.m. And I said, don't they end like at 6? And she said, if you want to stay, there's patients and the mentors will stay there with you. And
but I do, you know what? I don't turn any of the patients away.
I know you don't.
Well, if they come at 8 o'clock in the morning, they've been sitting there since 9 o'clock. They took 3 buses to get there. To me, even if the doctors there don't want to see them, then I personally will do them. My faculty will personally do them. And so I tell all the patients, we're not going to send anyone home. We're not going to make you sit here 6, 8, 10 hours and then tell you come back tomorrow. So everybody gets treated.
Yeah, it's an incredible operation. I mean, and then
everybody gets restored. I mean, we don't just ship out. I mean, as you know, we've got 14 full-time doctors working there, is Monday through Saturday, 6 days a week. So every patient gets restored. It's not just like we pack up and give them a transistor radio for being a good sport, and that's it. And they got a sinus lift they can do nothing with. No, they get the sinus lift, they get the bone graft, they get restored. It's by the full-time staff there.
Yeah, and that's another thing that impressed me, because I've had friends that have gone to some other live patient implant courses, and they show me the radiograph, and it's like, nice, the implant looks good, but what are you going to do with that when it's not in the right spot, it's not in the right angulation? And they say, I don't know, they just told us to put it here. And your foundation down there is doing dentistry on top of these implants, so that's awesome. So again, I want to thank you. I appreciate it. You have a very nice Christmas.
All the participants, and thanks for hanging in there and listening to everyone.
Yeah, so hopefully we'll get back in the symposium stuff, and I'll see you early in 2021, I hope.
Absolutely. We're gonna have fun.
Yeah, we always have fun. Always have fun. Good to see you, Aaron. Tell your family hi and have a very Merry Christmas.
Thank you.
Okay. Thanks.
All right, Jerome.
All right. Thanks, buddy. Appreciate you.
All right. Bye.
Bye.
So, Jerome, are you going to talk a little bit about how they get their credits and whatnot?
Yep. I just need to ask Arun to stop sharing his screen, and then I can. There we go. So while I'm pulling that up, you want to talk a little bit about our next guest?
Yeah, I'm really excited. And again, I can't stress enough how awesome this was tonight. I mean, I don't even do surgery. I'm thinking maybe I should be doing some of this stuff. And again, I thank Arun and Dr. Garg so much. So next month, January 21st, we're going to take a totally different look. Some of you may have heard of Nate Lawson. Maybe you've seen him lecture, read some of his stuff. He's very active. Dental Clinical Pearls, which is a big Facebook group. Nate is an incredible individual. He's doing so much research. He's the director of the Biomaterials Lab at University of Alabama, UAB, and he's doing some incredible things. And stuff that I'm really excited about is what he's done with the bonding to zirconia, because people say, oh, you can't bond to zirconia, and they're not keeping up with research if they say that. And so I've asked Nate to join us January 21st. It'll be the same time. And, look at the Facebook pages, look from Dental Intel. For those that on my database, you'll get the email on this, but look for it. We're going to talk a little about the stuff he's doing with wear compatibility of zirconia, because that's another big deal. Bondability, and they're also doing some really cool things. I mean, he's so imaginative, and he's a great speaker, and he's doing stuff. He just the other day he was doing something on thicknesses of matrix bands and thicknesses of articulating paper, in the science lab where they can do that. And it's like, I never really thought about some of those things, but very entertaining. It'll be very cool to spend 2 hours with Nate. So make sure you write this on your calendar, because you will not want to miss this at all.